You were prescribed one of these medications, Amlodipine, Losartan, or Lisinopril, and you were given information about the dose, the timing, and perhaps a brief mention of potential side effects. What you were almost certainly not given is the information in this video. Not because your prescribing doctor was negligent, because the standard prescription conversation is designed to initiate a medication, not to optimize it. And there is a significant gap between initiating these three medications and getting the maximum cardiovascular protection from them. That gap contains 4 specific pieces of information that most adults over 60 on these medications have never once heard. Information about timing that a major clinical trial found reduces cardiovascular event risk by nearly half. Information about a common food that can push your amlodipine dose to the equivalent of twice what was prescribed without you or your doctor knowing. Information about a dietary habit that patients on Losartan and Lisinopril are routinely doing that their cardiologist would want to know about. And information about the ankle swelling that most patients have been told to accept as part of the medication and that specific daily habits are making significantly worse. This video is about what happens after the prescription is written, the part of the conversation that most appointments never reach. A landmark study called the Hygia chronotherapy trial, published in the European Heart Journal and involving over 19,000 patients over 6 years, found that patients who took their blood pressure medication at bedtime rather than in the morning had a 45% lower risk of cardiovascular death, heart attack, and stroke than those who took the same medication in the morning, the same medication, the same dose, a different time of day, 45%. That is not a marginal improvement in an already controlled condition. That is the difference between a medication that is doing its job adequately and one that is doing it at its full potential. And the majority of adults currently taking amlodipine, Losartan, or Lisinopril are taking them in the morning because that is when they were told to take them, because morning dosing is the default, and because nobody explained that the cardiovascular clock has a different preference. My name is Dr. Nicole Harper. Before anything else, do not change your medication timing, your dose, or your dietary habits based on this video without speaking to your prescribing doctor first. Every item I am about to describe is a conversation to have with your doctor, not a unilateral change to make at home. Some of these interactions are serious. All of them are manageable with clinical awareness. None of them will be managed if you do not know to raise them. This video exists to give you the specific questions that most prescription appointments never get to. 4 questions, all of them worth asking, all of them with the potential to change the quality of protection your current medication is providing. Stay with me through all 4, because the 4th one involves a side effect. Most patients have been told is simply part of the medication that specific daily habits are making significantly worse, and that nobody has offered a practical alternative to managing. I want to tell you about a patient I will call Raymond. He was 70 years old, a retired teacher, careful about his health, faithfully taking his amlodipine every morning with breakfast for 3 years. His blood pressure was reasonably controlled. His daytime readings were consistently good. He came to see me not because the medication was failing, but because of 3 things he could not explain. His ankles had been swelling every evening since he started the medication. He had been told this was a known side effect and to live with it. He had been experiencing occasional dizziness and flushing that he could not connect to anything. And his most recent ambulatory blood pressure monitoring had shown something his GP had noted, but not specifically addressed. His overnight readings were higher than his daytime readings. The nighttime blood pressure that should have been dipping was not dipping adequately. When I reviewed his medication timing, his diet, and one specific daily habit he had maintained for years, 3 of his 4 unexplained problems had the same cause. We will come back to Raymond, because what changed for him, with no dose adjustment and no prescription change, is the reason I am making this video. Before I go through the 4 things, your first reaction to the timing information I am about to share may be, my doctor told me to take it in the morning, so morning must be correct. I want you to stay with me through the evidence before you reach that conclusion, Because the trial that changed the clinical conversation about blood pressure medication timing was published in one of the most respected cardiovascular journals in the world, involved nearly 20,000 patients, and its findings have not yet reached most standard prescription conversations. What I am about to tell you about the cardiovascular clock is not alternative medicine. It is peer-reviewed cardiology that most prescription pads have not caught up with yet. Thing 1. The timing that reduces cardiovascular risk by 45%. Blood pressure follows a circadian rhythm, dropping during sleep, rising sharply in the early morning hours, and peaking in the late morning. This morning surge, driven by cortisol, adrenaline, and the renin-angiotensin-aldosterone system, coincides with the highest rate of heart attacks and strokes across the entire 24-hour cycle. The majority of fatal cardiovascular events occur between 6 a.m. and noon. When blood pressure medication is taken in the morning, it reaches peak effect in the late morning or early afternoon after the most vulnerable window has passed. The medication performs best when the risk is lowest. During the overnight period and the early morning surge, when cardiovascular risk is highest, morning medication is at its trough concentration, providing its weakest protection at the moment the heart most needs it. Bedtime dosing reverses this relationship entirely. Medication taken at bedtime reaches its peak effect during the overnight period and the early morning surge, providing its strongest protection at exactly the moment the cardiovascular risk is highest. The Hygia chronotherapy trial documented this effect across all major classes of antihypertensive medications, including calcium channel blockers like amlodipine and RAAS, blocking agents like Losartan and Lisinopril. Think of bedtime dosing like positioning the fire brigade at the location of highest fire risk rather than across town. The same fire brigade, the same equipment, the same response time. Positioned correctly, the outcome is fundamentally different. The specific conversation to have with your prescribing doctor. I have read about the Hygia chronotherapy trial findings on bedtime versus morning dosing for antihypertensives. Given my specific medication and my blood pressure profile, would bedtime dosing be appropriate for me? Ask that question at your next appointment. Not next year, your next appointment. Raymond's non-dipping overnight blood pressure was the direct consequence of taking his amlodipine in the morning. His trough medication level during the night was insufficient to prevent the overnight pressure rise. That was the first thing. The second thing is the one that most patients on amlodipine have been experiencing as a mysterious side effect and whose cause most prescriptions never name. Stay with me. Thing 2, the grapefruit interaction with amlodipine that most patients have never been warned about. Amlodipine is metabolized in the liver by an enzyme called CYP3A4. Grapefruit and grapefruit juice contains compounds called furanocoumarins that irreversibly inhibit CYP3A4. When the enzyme responsible for breaking down amlodipine is inhibited, the medication accumulates in the bloodstream at concentrations significantly higher than the prescribed dose was designed to produce. Research has documented that a single glass of grapefruit juice can increase amlodipine blood levels by 30% to 90% depending on the individual's baseline CYP3A4 activity and the quantity of grapefruit consumed. Think of CYP3A4 like the exit door through which amlodipine leaves the body. Grapefruit locks that door. The medication that should have been leaving is still present, accumulating to concentrations the prescribing dose never intended. The symptoms of this accumulation are the same symptoms listed as amlodipine side effects on the package insert: dizziness, flushing, palpitations, headache, and the ankle swelling. I will describe in detail under Thing 4. Many patients experiencing these symptoms have been told they are simply sensitive to the medication when the actual cause is a food interaction producing an unintended dose escalation. Raymond had been drinking a glass of grapefruit juice every morning with his amlodipine for 3 years. His dizziness and flushing, the symptoms that had led to 2 separate GP appointments and a cardiology referral, resolved within 10 days of stopping the grapefruit juice. No dose change. No medication change. A food interaction that his original prescription had never mentioned. The interaction applies to whole grapefruit and all forms of grapefruit juice. including the juice in commercially prepared drinks that list grapefruit as an ingredient. Seville oranges, the bitter orange used in some marmalades, contain the same furanocoumarins and carry the same interaction risk. Sweet oranges, lemons, and limes do not contain furanocoumarins and are safe. If you are taking amlodipine and consuming grapefruit in any form, stop today and discuss the interaction with your prescribing doctor. The same CYP3A4 interaction applies to many other commonly prescribed medications, including statins, certain antihistamines, and some anxiety medications. If you are on multiple medications, ask your pharmacist specifically whether any of them interact with grapefruit. Today, not next month, today. Thing 3. The potassium risk for patients on Losartan and Lisinopril. Losartan and Lisinopril both work by blocking the renin-angiotensin-aldosterone system. Losartan as an ARB, angiotensin receptor blocker, and Lisinopril as an ACE inhibitor. One of the direct consequences of RAAS blockade is potassium retention. The kidney excretes less potassium than it would without the medication because the RAAS pathway that normally drives potassium excretion is blocked. In most patients at standard doses, this potassium retention is clinically insignificant, but in adults who simultaneously consume high dietary potassium, take potassium supplements, use potassium-based salt substitutes, or take other medications that raise potassium, the combination can push serum potassium into the range of hyperkalemia, elevated potassium, which at sufficient concentrations produces cardiac arrhythmia, muscle weakness, and in severe cases, cardiac arrest. Think of the potassium balance in the bloodstream like the water level in a tank that has both an inlet and an outlet. RAAS blocking medications narrow the outlet. High dietary potassium widens the inlet. With a narrowed outlet and a wide inlet, the tank fills faster than intended. The danger is not potassium itself. It is the combination of a medication-narrowed outlet with dietary or supplemental inputs that were calibrated for a patient without that narrowed outlet. The most commonly missed risk factors. Potassium-based salt substitutes, widely recommended as a healthier sodium alternative, contain potassium chloride that can significantly elevate serum potassium in patients on RAAS blocking medications. Many patients have been told to reduce sodium, purchase potassium-based substitutes as the alternative, and are simultaneously on Losartan or Lisinopril, a combination their GP may not have identified as a risk. Additionally, over-the-counter NSAIDs, ibuprofen, naproxen, reduce renal potassium excretion and significantly elevate serum potassium when used regularly alongside ACE inhibitors, or ARBs. Lisinopril plus regular ibuprofen for joint pain is one of the most common unmanaged drug-drug diet interactions in adults over 60. If you are on Losartan or Lisinopril, raise both of these at your next appointment. And if this video is giving you something specific to act on, tap subscribe. Most people watch this video and forget this channel exists by tomorrow morning. If this mattered to you, 1 second is all it takes. Thing 4. The ankle swelling from amlodipine and what makes it worse. Amlodipine produces peripheral edema, ankle, and lower leg swelling in approximately 10 to 15% of patients, with rates significantly higher in older adults and in women. The mechanism is specific and worth understanding because it explains why certain daily habits make the swelling significantly worse and why others reduce it. Amlodipine causes vasodilation. It relaxes the smooth muscle in arterial walls, reducing the resistance against which the heart is pumping. The challenge is that amlodipine preferentially dilates the precapillary arterioles, the small arteries feeding the capillary beds, more than the postcapillary venules draining them. This creates a pressure imbalance. More blood is being pushed into the capillary beds than can be efficiently drained out. The excess fluid is pushed through the capillary walls into the surrounding tissue, the ankle, the foot, the lower leg. Think of it like a garden irrigation system where the inlet valve has been widened, but the drainage has not been proportionally improved. More water enters the garden bed than the drainage can remove. The bed becomes waterlogged, not because too much water is being applied to the garden, but because the inlet-to-outlet ratio has been changed. The habits making amlodipine ankle swelling significantly worse. Prolonged sitting or standing without movement. High evening meal sodium driving overnight fluid retention. Hot environments causing additional vasodilation. An absence of the daily leg elevation protocol described in the Nocturia video in this series. The specific interventions that reduce it without medication change. 30 minutes of leg elevation at 5 p.m., evening sodium below 1,000 milligrams at dinner, and a 15-minute post-dinner walk activating the skeletal muscle pump that assists venous drainage. Raymond's ankle swelling, accepted as an inevitable amlodipine side effect for 3 years, reduced significantly within 2 weeks. His dose was not changed. His prescription was not changed. 3 daily habits were changed. The swelling attributed entirely to the medication had been significantly amplified by habits nobody had identified. Raymond came back at 6 weeks. 3 changes. No prescription alterations of any kind. His amlodipine was switched to bedtime dosing after a conversation with his GP, who reviewed the Hygia trial evidence and agreed the change was appropriate for his profile. He stopped the morning grapefruit juice entirely. He began the daily leg elevation protocol at 5 p.m. and reduced his evening meal sodium. His overnight blood pressure, the non-dipping pattern that had concerned his GP, had normalized on repeat ambulatory monitoring. His dizziness and flushing had resolved within 10 days of stopping the grapefruit. His ankle swelling had reduced to the point where he described it as barely noticeable by the end of the day. His cardiologist, reviewing the ambulatory monitoring results, asked what had changed in the management. Raymond's answer: nothing was changed in the management. Everything was changed in the information. 3 years of side effects that were all being caused by things nobody told me when the prescription was written. 5 rules that determine whether this information produces a safer, more effective medication experience or remains interesting but unacted upon. Rule 1. Have the bedtime dosing conversation with your prescribing doctor before changing anything. The Hygia trial findings are compelling, but bedtime dosing is not appropriate for every patient on every antihypertensive. Patients who experience orthostatic hypotension, dizziness on standing, may have this worsened by bedtime dosing that produces deeper overnight pressure reduction. Patients on diuretics alongside their